Next is V35, prostate cancer. On your post-take quadrant, you see a 69-year-old man who was admitted by new FI1 overnight with retention 2 liters urine. You notice that he is finding difficult to get out of the bed. What is your immediate management? So it looks like it's a missed emergency. The suspicion is of retention secondary to the spinal cord compression. I would ask him to stay in the bed and perform a full neurological examination to confirm a neurological deficit and ascertain the level. I would perform a digital rectal examination to look for prostate cancer, pelvic malignancy as a cause of this. Look for reduced anal sphincter tone. It is not uncommon for metastatic prostate cancer to present in this manner. What are your next steps? If a neurological deficit is confirmed, I would organize an urgent MRI scan of the spinal cord. Then I will request serum PSA, UNEs, LFTs, calcium. Review by an orthopedic and neurological team. The patient should remain on the strict bed rest until imaging has been performed and reviewed. MRI shows multiple METs causing spinal cord compression at T12 to L3 levels. Meanwhile, his PSA shown at 3000 nanogram per milliliter. What is immediate management? If there is isolated METs, a decompression laminectomy can be performed. However, depending on the local infrastructure or availability of emergency spinal surgery may not be recommended. In such cases, and for the patient with multiple METs, dexamethasone 8 mg BD and radiotherapy can an alternative. Urology referral to the urology unit should be made to plan treatment for the prostate cancer. What are the treatment options for the prostate cancer? Do you need to have a biopsy to confirm the diagnosis? A biopsy is not necessary until the diagnosis is in doubt or the patient is suitable for a clinical trial. The treatment options are surgical, subcapsular, bilateral orchidectomy, or medical LHRH antagonist, that is Degarelix, to lower the testosterone level as quickly as possible. If the patient has a spinal METs and needs radiotherapy, then an LHRH analog is started with androgen cover like cyproterone acetate 100 mg TDS or bicalutamide 100 mg per 2 weeks before and after. If there is hydronephrosis, then the patient may need stent or the nephrostomies. Can you discuss the mechanism of action of the various anti-androgens used in the prostate cancer treatment and the rationale for use? Testosterone is produced by testicles in response to the pulsatile release of LH from the anterior pituitary, which in turn is produced by the pulsatile release of the LHRH from the hypothalamus. So first, hypothalamus releases leukotrophin releasing factors which act on the pituitary, which release LH. LH act on the Sertoli cells of the testes, which produce the testosterone. For patients with a metastatic disease, LHRH agonist cause a surge of testosterone release followed by a castrate effect, as there is no pulsatile release of LH. Due to testosterone surge, the initial dose is covered by anti-androgen to prevent the testosterone flare. And to prevent the testosterone flare, which can make the spinal cord compression worse. LHRH antagonists exert a similar effect by blocking LHRH and do not need anti-androgen cover. They have a quicker onset of action and can be utilized first line when a rapid drop in testosterone is needed, or it's called compression. Estrogen preparations suppress androgen release and have some direct anti-androgen properties like stilboestrol.